Hello everyone, welcome to my YouTube channel Lighting the Knowledge Candle. I intentionally skipped the biostatistics portion and the sensitivity, specificity, positive and negative predictive value formulas and discussions regarding it because I thought it would be appropriate to discuss these biostatistics portion when I get the more clarity. I will be discussing it along with the PSM coaching notes after the finishing of the coaching notes. So as of now, regarding the first aid portions, we will be discussing about the public health sciences and ethics. We will be discussing the skipped portions later along with the coaching notes. Core ethical principles of public health sciences and ethics. Autonomy. Obligation to respect patients as individuals, that is truth telling, confidentiality, to create conditions necessary for autonomous choice, informed consent, and to honor their preference in accepting or not accepting medical care. Autonomy means obligation to respect the patients. We must respect the patients as individuals. We must tell them truth. We must maintain the confidentiality regarding their symptoms or signs or their disease or whatever they inform us. We must take the informed consent. We must accept their preference whether they want to take the treatment or not. It's up to them. Next, beneficence. Physicians have a special ethical duty to act in the patient's best interest. May conflict with an autonomy. An informed patient has the right to decide or what is best for society. Example, mandatory TB treatment. Traditionally, patient interest supersedes. That is TB treatment. When a particular patient has TB, it is in order to do good for the society, in order to prevent its communicability, it is always beneficial to do the TB treatment. But if the patient denies the treatment for the TB, then as obvious the patient interest supersedes. But physicians have a special ethical duty to act in the patient's best interest. Principle of double effect. Facilitating comfort is prioritized over potential side effects. Respiratory depression with opioid use for patients receiving end of life care. That is, for example, opioid is not to be used. At the end of the patient's end of life care, opioid can be used because facilitating comfort is prioritized over the potential side effects. Yes, of course, opioid has side effects, but it can be used in order to avoid the respiratory depression, in order to save the life of the patient, which is known as principle of double effect. These discussions comes under beneficence. Non-maleficence, do not harm, must be balanced against beneficence. If the benefits outweigh the risks, a patient may take the informed decision to proceed. If the benefits are more than the risks, the patient must be informed both about the benefits and the risks of receiving the treatment or surgery. Then it's about the it after this information, the patient takes the informed decision whether he has to take the treatment or not, which comes under non maleficence. Justice, to treat persons fairly and equitably. This does not always imply equally. Example, triage. We must not prioritize patients anywhere unless it is in emergency, like disaster management. In triage we have to take the preferences, but in other than the triage, we have to treat the patients fairly and equitably. Exception for this is triage. The next is decision making capacity. Physician must determine whether the patient is psychologically and legally capable of making a particular healthcare decision. Like this is more useful in psychiatric patients. We must estimate, we must understand whether the patient is able to take a decision, his mental status, or he is legally in a position to take the decision. Must determine whether the patient is psychologically and legally capable. Note that decisions made with capacity cannot be revoked simply if the patient later loses capacity. If the patient takes a decision when he has the capacity and later patient loses the capacity, then the decisions cannot be revoked. Intellectual disabilities and mental illnesses are not exclusion criteria unless the patient's condition presently impairs their ability to make healthcare decisions. The intellectual disability or mental illness is to such an extent that the patient is not in a position to make the decision. Capacity is determined by a physician for a specific healthcare related decision. Example, to refuse medical care. Competency is determined by a judge and usually refers to more global categories of decision making. Example, legally unable to make any healthcare related decision. Four major components of decision making include understanding. What do you know about your condition or proposed procedure or treatment? The patient must be given knowledge about the health, about his health condition, about the treatment that he is gonna receive, about the side effects, and then appreciation. What does your condition mean to you? What do you think your doctor is recommending this course of treatment? Appreciation. Next, reasoning. How are you weighing your options? Next, expressing a choice. What would you like to do? After understanding, appreciation, reasoning, expressing. Appreciation, understanding, appreciation, reasoning, and expressing. UARE. These are the four major components of the decision making for the patient. Next, informed consent. Informed consent is a process, not just a document and signature that requires. It is actually a process, disclosure, discussion of pertinent information, including risks, benefits, using medical interpreter if needed. That is, patient should be explained everything about the disease he has, the treatment he is going to receive, the risk factors while doing the surgeries or while he was receiving the treatment, etc. Understanding, ability to comprehend. Capacity, ability to reason and make one's own decisions, distinct from competence, a legal determination. Competence is something legal, capacity is something different. Voluntariness, freedom for coercion and manipulation. Voluntariness should be there. That is, the doctor or physician or surgeon is not supposed to do manipulation on their part. Patient must be willing to the treatment according to it must be his voluntary action. Patient must have a comprehensive understanding of their diagnosis and the risks or benefits of proposed treatment and alternative options including no treatment. Patient must be informed of their right to revoke written consent at any time, even orally. Exceptions to informed consent. Wipe it away. The situations where we can skip the informed consent. It can be remembered with the mnemonic wipe. Waiver. Patient explicitly relinquishes the right of informed consent. Legally incompetent. Patient lacks decision making capacity. Therapeutic privilege. Withholding information when disclosure would severely harm the patient or undermine informed decision making capacity. In fact, the hiding of information would give some therapeutic privilege, then we can do. Emergency situation. Implied consent may apply. Instead of informed consent, we can take the implied consent in emergency situation. Exceptions to informed consent. Waiver. Patient explicitly relinquishes the right of informed consent. Legally incompetent patient when it gives some therapeutic privilege. Emergency situation. Implied consent may apply. The next discussion would be consent for minors. A minor is generally any person less than 18 years old. Parental consent laws in relation to healthcare vary by state. In general, parental consent should be obtained, but exceptions exist for emergency treatment, such that if parents does not exist and there should be something to be done in an emergency, for example blood transfusion, or if minor is legally emancipated, example married, self-supporting, or in the military. If the minor is legally emancipated, he is doing something that a major does, that like the minor has got married, the minor is self-supporting or is in the military, then in such cases we can take the consent of the particular. Situations in which parental consent is usually not required. Even if it's a minor, the parental consent is not required in cases of sex, that is contraception, STDs, prenatal care, usually not abortion. Except abortion, any prenatal care. Drugs, substance use disorder treatment, rock and roll, emergency or trauma. If we have to do abortion in a minor, then the parental consent is must. But if we are supposed to give the prenatal care to the minor, then the parental consent is not required. Rock and roll, emergency or trauma. Physicians should always encourage healthy minor guardian communication. Physicians should seek a minor assent agreement of someone unable to legally consent, even if their consent is not required. Even if it is not required, we must seek a minor's consent. Physicians should always encourage healthy minor guardian communication. Advanced directives. Instructions given by a patient in anticipation of the need for a medical decision. Details vary per state law. A patient gives certain instructions in anticipation of the need for a medical decision. Certain instructions would be given by the patient. Oral advance directive. In capacitated patients, prior oral statements commonly used as guide. Problems arise from variance in interpretation. If patient was informed, directive was specific, patient made a choice and decision was repeated over time to multiple people, then the oral directive is more valid. Written advance directive delineates specific healthcare interventions that patients anticipates accepting or rejecting during the treatment for a critical or life-threatening illness. A living will is an example. Medical power of attorney. Patient designates as an agent to make medical decisions in the event that the patient loses decision making capacity. Patient may also specify decisions in clinical situations. Can be revoked patient if decision making capacity is intact. More flexible than a living will. Do not resuscitate order. DNR order, do not resuscitate order prohibits CPR. Patient may still consider other life sustaining measures that are intubation, feeding tube, and chemotherapy. Advanced directives, that is instructions given by when a patient is seeking a particular treatment. We are discussing these things again. Instructions given by a particular patient in anticipation of the need for a medical decision, that is you are taking the patient for a surgery. Patient gives an advanced directive that if in case and I may need, if in case in I get the need to do a CPR to me on my body, then do not do that. CPR should not be done on my body. It's an advanced directive given by the patient. In that cases, these directives vary per the state law. Oral advance directive, it is given orally. When it is repeatedly said to the multiple people, it is more valid. Written advance directive delineates specific healthcare interventions that patient anticipates accepting or rejecting during treatment for a critical or life-threatening illness. Medical power attorney, that is in case the patient loses the ability to take a decision, then this person should be take decision on behalf of me. This is something medical power attorney, and this is something known as medical power attorney, and this medical power attorney can be revoked in case of presence of decision making capacity for the patient. Next, do not resuscitate order, it's known as DNR or order. This is something, do not resuscitate order is something showed in Grey's Anatomy at various situations. Ventilator assisted life support. Ideally, discussions with patients occur before ventilator support is necessary. However, information about patient preferences may be absent at the time patient require this intervention to survive. Medical decision making frequently relies on surrogate decision makers, patient identified or legally appointed, when discussing the continuation or withdrawal of ventilatory support, focusing on both the prognosis of the condition and the believed wishes of the patient. If surrogates indicate patients would not have wanted to receive life support with ventilation, withhold or withdraw life support regardless of what the surrogate prefers. If the decision is made to withhold or withdraw life support, involve palliative care, chaplain services, and the primary care physician in medical discussions with the family and provide emotional support. Surrogate decision maker. If a patient loses decision making capacity and has not prepared an advance directive, individuals, surrogates who know the patient must determine what the patient would have done. There is someone who is known to the patient. They become the surrogates, and if they think as like the patient thinks, and they decide what the patient would have done if he was alive, if he was in a decision making capacity. Priority of surrogates. What's the priority of the surrogates? If the spouse is present, then definitely the spouse is the first surrogate. Then if the spouse is not present, then it is adult children. If not adult children, then it is parents. If parents were not there, then it is adult siblings. Other relatives, the spouse chips in, will comes in later. Next comes the confidentiality. Confidentiality respects patient privacy and autonomy. If the patient is incapacitated or the situation is emergent, disclosing information to family and friends should be guided by professional judgment of patient's best interest. That is, patient should have, we must have the consent before disclosing his condition even to his family. The patient may voluntarily waive the right to confidentiality. Example, insurance company request. Right to confidentiality. The patient may voluntarily waive the right to confidentiality. General principles for exceptions to confidentiality. Potential physical harm to self or others in serious and imminent. That if the patient is suicidal and he asks you to maintain confidentiality of his condition, then we are not obliged to follow the confidentiality rule. We can disclose about his condition, that he is suicidal, to his parents or his guardians. Alternative means to warn or protect those at risk is not possible. Steps can be taken to prevent harm. Examples of exceptions to patient confidentiality include the following. Saved is the mnemonic. Patients with suicidal or homicidal ideation. If the patient has suicidal or homicidal ideation, then confidentiality can be revoked. Abuse. Patient If the patient has the possibility to abuse, then it can be revoked. Duty to protect. State specific laws that sometimes allow physician to inform or somehow protect potential victim from the harm. Patients with epilepsy and other impaired automobile drivers. If you have epilepsy and you are doing driving, then it's definitely a risk for the people who sit in the car, and it's a risk factor for you that you may even die if you get an epilepsy episode while you are driving. Then you need not maintain the confidentiality. Reportable diseases, that is STDs, hepatitis, food poisoning. These are the reportable diseases that does not need to be maintained confidentially. Physicians may have a duty to warn the public officials. Like if a particular person has TB or Ebola and if he asks not to disclose, then no, we have to disclose the patient condition in order to isolate. Or if a driver is having the epilepsy, then the owner must be informed about his condition so that he loses his job, so that his health condition is not detrimental to his life or to someone else's life. Next thing is accepting gifts from patient, a complex subject without definitive regulations. Some argue that the patient-physician relationship is strengthened through accepting a gift from a patient, while others argue that negative consequences outweigh the benefits of accepting any gift. In practice, patients often present items such as cards, baked goods, inexpensive gifts to physicians. The physician's decision to accept or decline is based on an individual assessment of whether or not the risk of harm outweighs the potential benefit. Physicians should not accept gifts that are inappropriately large or highly valuable. Gifts should not be accepted if the physician identifies that the gift could be detrimentally affect the patient care. Gifts that may cause emotional or financial stress for the patient should not be accepted. If a gift violates any of the guidelines above, the best practice is to thank the patient for offering a kind gift and politely indicate that it must be declined. During this conversation, it should be emphasized that the incident does not influence the physician-patient relationship in any way. Next, patient-centered interviewing techniques. Introduction. Introduce yourself and ask the patient their name and how they would like to be addressed. Address the patient by the name and pronouns given. Avoid making gender assumptions. Sit at eye level near the patient. Agenda setting. Identify concerns of the patient and set goals by developing joint agenda between the physician and the patient. Reflection. Actively listen and synthesize information offered by the patient, particularly with respect to his concerns. Primary concerns must be listened with a lot of patience. Validation. Legitimize or affirm the patient's perspectives. Recapitulation. Summarize what the patient has said so far to ensure correct interpretation. Facilitation. Encourage the patient to speak freely without guiding responses or leading questions. Allow the patient to ask questions throughout the encounter. Next is establishing rapport. We can remember the components of establishing rapport with the mnemonic pearls. P. Partnership. Work together with patient to identify primary concerns and develop preferred solutions. Empathy. Acknowledge the emotions displayed and demonstrate understanding of why the patient is feeling that way. Apology. Take personal responsibility when appropriate. Respect. Commend the patient for coming in to discuss a problem, pushing through challenging circumstances, keeping a positive attitude or other constructive behaviors. Legitimization. Assure patient that emotional responses are understandable or they are common. Support. Reassure patient that you will work together through difficult times and offer appropriate resources. Pearls. Partnership, empathy, apology, respect, legitimization, and support. Delivering bad news. The delivering bad news components could be remembered with the mnemonic spikes. Setting. Offer in advance for the patient to bring support, eliminate distractions, ensure privacy, and sit down with the patient to talk. Perception. Determine the patient's understanding and expectations of the situation. Invitation. Obtain the patient's permission to disclose the news and what level of detail is desired. Knowledge. Share the information in small pieces without medical jargon, allowing time to process. Assess the patient's understanding. Emotions. Acknowledge the patient's emotions and provide opportunity to express them. Listen and offer empathetic responses. Strategy. If the patient feels ready, discuss treatment options and goals of care. Offer an agenda for the next appointment. Giving control to the patient may be empowering. Ask how they feel a problem might be solved and what they would like to do about the plan of action. Gender and sexuality inclusive history taking. Avoid making assumptions about sexual orientation, gender identity, gender expression, and behavior. A patient who identifies as heterosexual may engage in same sexual activity. Use gender neutral terms. Refer to a patient's partner rather than assuming a spouse's gender. A patient's sex assigned at birth and gender identity may differ. Consider stating what pronouns you use when you introduce yourself. Like, for example, I'm Dr. Smith and I use she or her pronouns, and asking patients how they would like to be addressed. Reassure them about the confidentiality of their appointments and be sensitive to the fact that the patients may not be open about their sexual orientation or gender identity to others in life. Do not bring up gender or sexuality if it is not relevant to the visit. That is, example, a gender non-conforming patient seeking care for a hand laceration, you need not confirm the gender identity of the patient. Cultural formulation interview. Identify the problem through the patient's perspective. Ask the patient to describe the problem in their own words or how the patient would describe the problem to their family and friends. Identify cultural perceptions of factors leading to problem. Ask the patient to explain why they think they are experiencing their problem. Identify how the patient's background influences their problem. Ask the patient about what makes their problem better or worse. Investigate roles of family, community, spirituality. Identify how culture may impact current and future interventions. Ask the patient if they have any concerns about the current plan of treatment and if they have any suggestions. If they do not want to follow medical advice, investigate if there is a way to combine their plans with the standard medical regimen. Identify possible barriers to care based on culture. Ask the patient if there is anything that would prevent them from seeking care in a standard medical institution. Probe for explanations and what may increase the chance of maintaining a good patient physician relationship. Motivational interviewing. Counseling technique used to facilitate behavior modification by helping patient resolve ambivalence about change. Useful for many conditions. Nicotine dependence, obesity, helpful when patient has some desire to change, but it does not require that the patient be committed to making the change. May involve asking patients to examine how their behavior interferes with their life or why they might want to change it. Assess barriers, food access, untreated trauma that may make behavior change difficult. Assessing a patient's readiness for change is also important for guiding physician suggested goals. These goals should be specific, measurable, achievable, relevant, and time bound. SMART: specific, measurable, achievable, relevant, and time bound. Trauma informed care. Patients with history of psychological trauma should receive thorough behavioral health screenings. Regularly assess mood, substance abuse, social supports. and the risk of suicide. Focus assessments on trauma related symptoms that interfere with social and occupational function. Do not probe into details of the incident. Always be empathetic. Do not ask invasive questions requiring the patient to describe the trauma in detail. Ask permission prior to discussion. Before the physical exam, reassure patients that they may signal to end it immediately if they experience too much physical or emotional discomfort. Offer the presence of additional staff for support. Psychological counseling may be indicated. Follow up counseling is offered. The 4 R's of trauma informed are realize, recognize, respond, and resist re traumatization. Challenging patient and ethical scenarios. The most appropriate response is usually one that acknowledges the issues, validates emotions, open minded, empathetic, patient centered. It often honors one or more of the principles of autonomy, beneficence, non maleficence, and justice. Appropriate responses are useful of patients and other members of the healthcare team.